Next speaker is Dr. Paul Liknaitzky from Monash University in Australia. He's an experimental psychologist and he runs various studies with a psychedelic in various disorders. And he presents, this is the title. I heard him this morning already presenting the Australian perspective. That's very interesting. And it's a field experiment for the world. So, Paul, thank you for being here.
Thanks, Gert. Thanks, everybody, for coming down. Appreciate it. All right, let me figure out how to do this. So here are some of my main affiliations. I head up the Monash Clinical Psychedelic Lab. I'm co-founder of Clarion Clinics, soon to open its doors, I hope, and scientific advisory to Mind and also Inconnex Healthcare. Here are the wonderful folk that I work with in my lab, where we develop and test a range of psychedelic-assisted therapies, and we're conducting all kinds of training programs within the lab and also in collaboration with others. This is just to give you a little view into one of our dosing rooms, and also here's a group of therapists who finished up a MAPS training that we co-hosted not very long ago. So there is an enormous amount of interest and demand for training in Australia, particularly with this new authorized prescriber scheme coming on, and the vast majority of the 70 people that we were training with here had intentions and plans to work within authorized prescriber clinics, this new field experiment that Gert refers to. Just to say, in brief, while there are all kinds of complexities, guardrails, concerns, excitement, for me personally, one of the things I'm most excited about as a clinical research scientist in moving into the clinic space is the opportunity to build completely patient-centric treatment models. You know, in research trials, we're limited in all kinds of ways. We need typically brief interventions, one size fits all, and an enormous amount of assessment and the like. So for me, it's really wonderful to have this opportunity to move into service delivery and really go for gold with respect to outcomes. All kinds of things to work out. And one of the things that we need to work out is how to train therapists well and how to assess that. So I'm going to talk to you today about psychedelic-assisted training. This is one potential aspect of training psychedelic therapists. And I just want to preface this by saying this is really our first foray, our first step into running this kind of research and assessing it scientifically, but it's really like a case series. This is not, you know, high-powered, rigorous science. This is the first step to pilot this out. And one of the key things that we're wanting to do in this study was learn how to do it. So the know-how for us was just as important as the data. So I'm going to give you a little bit of background here, starting with a few quotes. So Hoffman said, personal psychedelic use may provide the doctors with direct insight based on first-hand experience into the strange world of LSD inebriation and make it possible for them to truly understand these phenomena in their patients, to interpret them properly and to take full advantage of them. Tim Leary said, I learned more about psychology in the 5 hours after taking these mushrooms than in the preceding 15 years of studying and doing research on psychology. And Huxley said, I think the people who would benefit most of all are professors. I think it would be extremely good for almost anybody with fixed ideas and with a great certainty about what's what to take this thing and to realize the world he's constructed is by no means the only world, and there are these extraordinary other types of universe. So these ideas about professionals in the community having these experiences as useful are obviously not new ideas. Here is some of the rationale for us doing this study. Firstly, therapists say it's useful, and this comes from anecdotes and early reports. Therapists who have their own psychedelic experience talk about things like increased attunement and participants having trust in them, and perhaps even the ability to adequately inform your participants about what they're going to undertake in their dosing sessions. Also, patients seem to want it, so there are a few examples of this. A recent Mechanical Turk sample indicated a preference for the guide to have prior psilocybin experience. It's also very common. This was 88% of the USONA therapists, I believe, had prior psychedelic experience. And it's worth saying, while not a whole lot of indigenous shamanism necessarily involves psychedelics, where they do, generally the norm is that the shaman consumes the psychedelics, often in the absence of the quote-unquote patient consuming the psychedelic. And there's a little bit of precedent. So Spring Grove study, MAPS training, and TheraSeal. I'll take you through some of that. So Spring Grove LSD training study went from 69 to 74. It was in 74, that was the last legal dose of LSD. And this was all buried. There was a research that was conducted, and in those days, of course, methodological standards were not up to our contemporary standards, and a lot of this research was buried. Liz Nielsen dug it up and pulled together some of it and published it in a paper not too long ago. And this just shows that the educational value rated by these therapists was very high. This is the only known formal study with published data, and it's just worth noting this in terms of what's come before, because the study itself had substantial methodological limitations. And this report, which was a valiant effort on Liz Nielsen's part, included, I think, 1 in every 5 patients randomly selected, with lots of missing data throughout there. So really, it's a pretty scant record to date. But here are some quotes from this study reminding me how good the guide has to be. And I feel the experience is one of the most important in my life. I feel much more terrified than ever before of people taking the drug without proper set and setting. And I feel it is one of the many tragedies of our contemporary culture that responsible experimentation and training with the drug is so difficult to come by. Not much has changed. In the MAPS training trial, the MT1 trial, which finished up a couple of years ago, 90% of those therapists who underwent MDMA in like a healthy volunteer study said they rated the experience as greatly useful to their qualifications to provide MDMA psychotherapy, with an exemplary quote: "This was by far the most vital part of my training for conducting safe and effective MDMA-assisted therapy." And TheraSeal, the nonprofit in Canada, got 19 exemptions in 2020 for their healthcare professionals to receive psilocybin mushrooms as part of their training. But none of these were assessed formally, none of these have been published. So we wanted to do this, and so here enters the Monash Psilocybin Therapist Study. It's a world-first study approval to test psilocybin as a therapist training tool. By the time I attempted to get the main clinical trial that this is associated with up, I had a reasonable amount of confidence that our ethics committee would approve it. I didn't have high confidence that they would approve this part of it. As it turned out, they did, and I think possibly one of the things that contributed to that is that the justification was risk mitigation. It was within the clinical trial, which is psilocybin for generalized anxiety disorder, which finishes up later this year, and we had a whole risk mitigation plan, and part of that is training therapists well, and part of that was this therapist exposure option. 2 key purposes. One is that the therapists get this exposure, and the other is that the therapists get to have their first sessions in the therapist mode with a quote-unquote healthy volunteer. And some of the obvious key questions: is it safe? Is it feasible? What are the professional or personal benefits and harms? And what are the key considerations for practice? This is, that 5th question there was probably the one that I was most interested in. And then also we wanted to ask their subsequent participants, their clinical participants, what their attitudes were about their therapists having psilocybin as part of their training. Now that's ongoing. I'll present some preliminary data on that, but that study is not yet complete, and we're asking them before their treatment and after their treatment. One of my hypotheses is that clinical participants will rate therapist exposure as beneficial, or they'd like to have their therapist have that experience before they undergo the treatment, and then I hypothesize that after treatment they will rate that even more valuable. So this was not just folk that applied from anywhere. These were people that were joining our lab and our team. So these are qualified, experienced mental health clinicians, mostly quite senior people from a range of disciplines: psychiatry, psychology, psychotherapy. And they joined the team through a rigorous selection process. And then we provided 3 months of training that was assisted by a whole lot of wonderful folk in Australia and around the world. And you can see some some of the organizations there. And then, and just to say, and this is relevant to something I'll note later, that this extensive training over 3 months, which is about 120 hours, so similar to the MAPS intensity level, was a no-fee training, and I'll reference that again. It was obviously optional for therapists to participate in this psilocybin exposure, and the therapists continue to have supervision for the duration of the trial. So just to give you a sense of how much support there is there and how much training there is there. This is what it looked like. Similar general and so psychiatric and physical screening as the clinical participants undergo, with a few key differences. And then we conducted a baseline assessment, a single prep session for 90 minutes. Next week was a dose day, 25 milligrams of psilocybin, 2 therapists all the way through. And day after the psilocybin exposure was 1 integration, 90 minutes long. So it's a very truncated, quote unquote, treatment. And then we assessed it 1 day, 7 days, 3 weeks. And assessments are ongoing. The qualitative work is ongoing now. And it's very unfortunate that one of my PhD students, Georgia, couldn't make it to the conference in the end, but she was going to present on the qualitative data, which is, in many respects, the most interesting part of the study. 14 therapists underwent this exposure, and not all therapists who work on this trial participated. It's worth noting. You can see there's some basic demographics there. Mean age 42, 2/3 man. What else can I draw your attention to? Highly educated cohort. Mean duration of 14 years working professionally in mental health care, and interestingly, only 2/3 with lifetime psychedelic use. Here are some of the acute effects. So we wanted to just understand what kinds of experiences they were undergoing, and there's much more data than what I'll present, but I'll give you just a little bit of it. This is the drug experiences questionnaire, and as you can see, this is reasonably high ratings of intensity. Something that I found interesting was intensity is rated high, but wanting more is rated quite high too. And indeed, in the debriefs afterwards, we did learn that we could certainly go up beyond 25 milligrams of psilocybin. In terms of the nature of this experience, the meaningful and challenging components, these are the Johns Hopkins questions that are asked across lots of studies, so I wanted to cross-reference, and you can see there, it is indeed rated in this cohort as a meaningful experience on the whole. You can see there, even with one person saying it was the most meaningful experience of their lives. And in terms of challenging experience, you know, moderate, middling. We've certainly seen some studies where the challenging experiences are scored higher among a more clinical cohort, but in general, not extremely challenging for most people. There's the MEQ and the CEQ, and for those of you familiar with these two scales, the mystical experience scale and the challenging experiences scale, you might see that these indeed were big experiences, big mystical experiences on the whole, and also, again, not extremely challenging experiences. You can see grief was quite a common challenging experience that people reported. And here are the outcomes. So, in terms of the therapist rating the utility of this experience, very high ratings of professional benefit, no professional harm reported. Very high ratings of personal benefit, and 1 instance of personal harm reported. I'll tell you about that. No serious adverse events, no severe adverse events, no withdrawals from the study, and here are a few quotes. It was a pivotal moment for me professionally and personally, profoundly improved my understanding of the work. Someone else said, I think especially given altered states are quite foreign within our culture, it was enormously helpful. Brought a level of detail to the treatment that would be very difficult to achieve otherwise, extremely valuable. I am more open and honest with my peers and feel under less pressure at work. In terms of the person that referenced personal harm, this is the only reference to that, and this was the explanation. Having such a radically altered state experience in the middle of a busy life knocked me out of rhythm. This is not harmful, but it's challenging. So as you can see, on the whole, this was a very safe exposure for this cohort. In terms of their self-rated improvements or declines in therapeutic competencies, all the competencies that we listed improved, and they improved very highly by their account. Empathy, alliance, motivation to do this work, confidence, attunement, and so on. There's some exemplary quotes to do with empathy. Wonderful to gain insight into the dosing experience exactly as it would be for the participants, which was referring to the context because they did it in the same clinical rooms, to know more intimately the challenges they will face. There is no doubt that having gone through the experience, I feel in a better place to be with the participants and understand and empathize with what they're going through. In terms of alliance, our first participant asked if we had had the medicine. When we said yes, I could see she immediately felt more relaxed. If I had not, then I'd feel a bit like a charlatan. And attunement was also reported, capacity to attune effectively to participants' experience. When we asked the therapist to rate whether this self-experience was necessary and or sufficient for training mental health care workers, this is what they said. So keep in mind, this is not for training anybody. This is if you were to take people who are already qualified and competent mental health care workers like psychiatrists and psychologists, and the only thing you provide them to be trained as a psychedelic therapist is exposure to psilocybin at high dose. 13 out of 14 said it's necessary. I was surprised by that. When we asked, is it necessary that this exposure happens in a therapeutic context, or it could happen anywhere, maybe ceremonial, maybe recreational? And here to Max's last talk, they agreed with you. Therapeutic context was unanimously voted as what was necessary for this kind of exposure. When asked if it's a sufficient training, all said no. We then asked the clinical participants in the trial, and this is, as I mentioned, ongoing, so this is only a subset, about 50 or so, and it's only baseline because we haven't yet gone, we haven't done data lock and unblinding yet, we're not complete, so we don't know what they say after their treatment. In terms of ratings of importance for their therapist to receive this as part of their training, it was rated as very important, extremely important. In terms of necessary, 2/3 said yes, 1/3 said no, not necessary. Here are some quotes. Heightens my confidence, so this is from the clinical participants, heightens my confidence and trust in my therapist, enhances our therapeutic relationship. It would be like the blind leading the blind, able to relate to patients in a deeper way, demonstrated the confidence they have in the treatment and their sincerity to support participants. It's like they're drinking the chalice of poison metaphor. Really reassuring to not feel judged for what and how I express myself during that vulnerable state. I had assumed that they had already had some experience with psychedelics. And then when I looked into those that said no, not necessary, the vast majority of those that said not necessary said something like this: either more important is the talent, compassion, training, and insight of the therapist, or not critical but beneficial. Some people took that question to imply like that we would mandate it, and they would say, no, you can't mandate this, this can't be obligatory, which I agree with. So what are the impacts of what we learned here? So firstly, jumping around, key findings. This is the first case series evidence for the use of high-dose psilocybin with support as a safe and potentially valuable therapist training tool. There's strong support from the help seeker community for this exposure for therapist training, and it needs to be embedded within a broader psychedelic-assisted therapy training, not isolated. The method of use that we developed was very useful, and I'm very keen to pursue this in subsequent trials and training programs going forward. Here are some key highlighted points. Firstly, we went through a specialized informed consent process. So, you've got, in our case, a group of colleagues who are then going to undergo psilocybin exposure and work with each other and then go on to work with clinical participants. It's obviously a very complex situation with multiple relationships and all kinds of things that need to be taken care of. So we went through this process of a group consensus on the approach we were going to take, how we were going to support one another, who was going to support one another, and then there was confidential choice in the selection of each individual's therapists. We dealt with this multiple relationships thing very extensively and explicitly. So, these individuals are at times a therapist, at times a colleague, and at times a participant. And so we did a number of things there, including establishing multiple lines of reporting. So the reports all didn't come to me. There was a specialized confidentiality. So normally in our trials, the therapists have access to most of the data and can sometimes get access to the video material from all the clinical sessions. In this case, they could only get access to material that was to do with the session that they were therapist on, not the whole study. And we also ascertained that we needed to have professional structures in place, but we also needed to limit the professional distance that can be in play in a professional context. That is, when you went in as a participant, you put your professional hat off at the door and you went in with your own real material and you know, in your personal capacity. And the reason for this primarily was safety, but also usefulness, that we really wanted to create a space where people could be truly vulnerable. And that seemed like an important ethical consideration. So what I would suggest here, just as a general gestalt of how to potentially think about this rolled out, is to put additional emphases on the systems around this kind of training approach to be very professional, to use, you know, to formalize things a lot, to go through a lot of training, to get very clear on things like multiple lines of reporting and confidentiality and the like. So it's like excessively professional. Then a little bit closer in to really emphasize authenticity in relationships in the collegiate group, that you're really building a bridge into the situation, that you're not kind of creating the opportunity for, you know, a massive disjuncture between the professional context and then psychedelic dosing sessions. And then right at the heart of it all, with the psychedelic dosing session, to emphasize the personal, not the professional, for the participant. And I think in that way, we can create a safe container to do this. And safety is held both by, you know, very professional structures and the capacity to be very vulnerable. I think these things need to both be considered. So, final few points here, some considerations. Firstly, we need to also consider if there are cheaper, easier, more accessible alternatives, possibly holotropic breathwork, although we were having a chat yesterday about holotropic breathwork and how in some cases it's not as safe or not as easy to undergo. But there needs to be alternatives to this as a training tool, of course, and because some people wouldn't choose to do this and some people maybe it's not safe to do this. Also, within a research trial context where this is being offered, like in our study, my view is that it's problematic to access that research trial through a prior paid training. So it reminds me a little of my brother's early business. He became a commercial pilot, but he didn't have a license to fly people for money. So he sold very expensive T-shirts and gave a free flight. And I think we need to watch out that research participants can't pay to be in research trials. And if the only way they get access is because they paid to do a training, there's some ethical concerns there. We also need to continue to overcome prejudice. There's, you know, prevailing stigma and biases around this and judgments of people having an agenda if they have their own psychedelic experience. So I think this is one of the new frontiers. We're now comfortable talking about this as a treatment in mental illness, but this is a new frontier in the stigma battle. We also need to consider inequities of access. There may be some people, some professionals who would like access to something like this in the future, but due to their particular context may suffer greater stigma than the rest. And this is something that's very, you know, of interest to me, that with folk undergoing psychedelics as a training tool, particularly if it is their first or only psychedelic experience, there is this risk of what I'd refer to as narrowed therapeutic support, that is reduced psychological safety for participants, primarily through a kind of projection that I had this kind of experience, and so my participants or my patients need to have this kind of experience, or, well, you know, I believe in this medicine, so, you know, the only thing that you can experience is something positive. I think that's dangerous. This idea that everything that happens should have happened, I think, is problematic. This idea that there's no bad trip, I think, is problematic. And I think self-exposure can increase the potential for discounting negative reports and outcomes and projecting your view onto your participants or patients. And then this rather unusual, ironic potential in the future that we may find ourselves in the closet about not having had psychedelic experience in the future. And that's a problem we should avoid. So future directions, and then I wrap up. We need to do further research to determine the utility of this, of course. So firstly, we've done this study with a small cohort. It's a case series analysis, therapist reports, and it's looking interesting and useful. We've now done the study, and we'll be finished it soon, with patient reports on their attitudes towards this as an exposure. We then need to assess competencies using an objective competency framework, and we need to see whether psilocybin or MDMA exposure improves objective competencies, and then ultimately we need to see whether therapists with this kind of exposure produce differential outcomes in their patient cohorts. Not easy to do, but something we should definitely do. We're developing guidelines and best practice, and we'll continue to do this research going forward. I want to suggest boldly, perhaps, that we need to also consider the utility of exposure for other stakeholders in this mental health network: researchers, policymakers, clinic directors, family members, and so on. And MAPS's original dream of on-label MDMA for therapist training may be being dropped. I'm not certain, but I think this is something that we should consider for on-label utility. I want to acknowledge all the people that have been involved in this, wonderful colleagues that I've worked with, and in the interest of time, I'll end there. Thanks.
Thank you, Paul. We have time for a few questions. Max was first.
Thank you very much, Paul. So we also train therapists for psychedelic therapy, but we don't have it so difficult as you, because we train individuals who come from all over the world or from Germany, but we don't train teams yet who work together and who have all kinds of complicated relationships, also hierarchies within the teams. And I was really impressed by all the measures you took and the level of thought that went into that. But I was still wondering, can you say something about possible problems that you encountered or that could have happened? Or did you collect perhaps even some data about how this changed the teams, or if this led to any problems, but also maybe improvements in how the teams work together?
Yeah, good question. The qualitative research that is being conducted still really gets into a lot of that. All the therapists underwent interviews, and they continue to, and there's workshops with them to assess this whole process and how they feel it informed their work for 2 years on this trial. I was a bit nervous. Yeah, that's why we went to all these levels to take care of things. You know, psychedelic experience is unpredictable. All kinds of things can come out, and people can find themselves regretting exposing themselves to that degree. But we created such a safe container of trust and care that I think in this particular group of very close people, it ultimately felt like a very safe thing to do. In fact, they had the opportunity to select their dyad partner or not. You know, the person they were going to work with for 2 years, and all of them selected their dyad partner. And it was an incredibly bonding way to start their career together. But I do think going forward, if we were to roll this out in groups with hierarchies, or, you know, you might not have hierarchies in the whole training, but you might have 2 or 3 people that get trained from one institution. They've got their own hierarchy. So I don't think we can avoid dealing with these problems or these challenges. And I do feel more concerned about just, you know, how this works if you roll it out, and taking very good care of all of that stuff in the dose room. Yeah.
There was a question up there. Chris, the second microphone is coming. Short question, short answer, please.
Okay, sorry. Yeah, thanks, Paul. So I can see that we can't require people to do this, right? We can't require psychedelic therapists to do this. But what do you think about the idea that patients need to know whether they've done it or not as a matter of informed consent? I mean, my analogy just really quickly is, if I went on a meditation retreat and then discovered that the person leading the retreat had never done a meditation retreat themselves, I would be appalled, and I don't see any extremely relevant differences.
Yeah, it's a great question, and I think I concur, just with one caveat, which is in the context of the legal situation we find ourselves in. Most therapists, as you saw in the early slides, have had these experiences, and they're generally asked, and they're often put in an awkward position, have to come up with some political, you know, sidesteppy way of answering typically. So I agree with you. I think it is an important thing to be able to tell your participants or your clients. I just feel a lot of sympathy for the folk who have only managed to attain this kind of experience illegally and the kind of complex situation they're put in. But I think that's a temporary problem. Yeah.
One last question. I think faster.
Thanks. It's an easy one. Just on that, do you have any, like, how many people opted out, and do you have any data on why they chose not to do it?
How many of the therapists on the trial opted out? I'm not sure I want to answer that, because it gives you some, it maybe exposes, you know, the probability of identities or something. They're a tiny minority, opted out. Yeah, I don't have data on that, but yeah, in one case it was life circumstance and not feeling in the right space for it. Another one, it was psychotropic medication that was contraindicated and they didn't want to taper and so on. So yeah, it was usually, you know, very kind of predictable circumstance, yeah.
We have to stop here. The next thing is going on right now here in this room. Thank you again, Paul.
Thanks.